Medicaid covers more than 70 million people. It used to be 80 million. Last year, it went through the biggest change to its financing in its history, I think, since founding. The 2025 reconciliation law cut federal Medicaid spending by an estimated $911 billion over 10 years, almost $1 trillion in cuts. And it added work requirements, shortened eligibility checks to every 6 months, and it limited how states can raise money through provider taxes. For most of last year, those were words on a page, and this year the rules have actually arrived. States now have a real deadline, and many of those big changes start January 1st, 2027. My guest is Verlon Johnson. She chairs MACPAC, the commission that advises Congress on Medicaid. She spent decades at CMS, and she now helps build and run Medicaid systems for states at Acentra Health. And she's seen this program from the federal side, the state side, and the technology side. And today we're going to talk about where Medicaid stands, what these changes take to implement, and whether the program can hold. Welcome.
All right. Thank you so much for having me here. I appreciate it. Anytime I can talk about Medicaid, I am here to do that.
Amazing. Maybe you can start by talking a bit about your background, which is really interesting and unique. You have an incredible point of view on where we are with Medicaid, all the things happening at CMS. I know you and I follow the alphabet soup of all of these different rules and programs. So would love to hear about how you got where you are.
Yeah, thank you, Lisa. And again, thank you for inviting me to the program. I watch you all the time, and I always thought, oh gosh, I would love to get on there. And here I am, right? So, as you said, I've really been fortunate to see Medicaid from several different perspectives throughout my career, and I've been at it for over 30 years at this point. So, obviously, I started at CMS. There, I worked on the Medicare side for about 10 years, and then spent the rest of my time there on Medicaid, working closely with states on their policy and implementation, both from a central office and a regional office perspective at that time. You mentioned that I also chair MACPAC, but I will say that as I'm talking today, everything that I say, I'm representing for myself and not MACPAC for sure. But there, I do have the privilege of really serving and working with a number of amazing commissioners and staff to really help provide independent, evidence-based policy recommendations to Congress and states alike. And at Acentra Health, I do serve as a Chief Government and Corporate Affairs Officer here. I've been with Acentra for about 6 years now, and here I have the opportunity to work with states every day as they try to modernize their Medicaid programs. But I will say, though, that the common thread for me through all these experiences is very simple. It's my North Star. I've always believed that Medicaid is really the most important program that we have in this country. Because if you think about it, Lisa, as we've talked about it, I know 101, it touches children, older adults, people with disabilities, individuals with behavioral health needs, families who rely on it very much every day because they're the most vulnerable in their most vulnerable parts of their lives. So whether we're talking about technology or policy or AI, I know we'll get to that too. I always come back to that one question for sure, and that is, how does this improve people's lives? And so that's really important to me because I really believe in this population, and I really want to make sure that they thrive.
Yeah, I couldn't agree more. As somebody who grew up on Medicaid, I was lucky enough to be on Medicaid here, Medi-Cal in California at the time when they were funding some, certain critical things for children. And, some of those hard decisions have to be made now as budgets are getting cut. And so, there was a moment in time where I had a particular level of coverage. Who knows if that level of coverage will be available for kids in the future here in California or elsewhere in the country.
Yeah, exactly. That's exactly right. And when you think about Medicaid, I really see it really kind of entering this new era, right? We've just come obviously through the unwinding, states have been really implementing significant new federal requirements that, you talked about at the beginning of our segment for sure. And then, as you know, technology continues to evolve so rapidly as well. And so as we think about these things, particularly around AI and how it's reshaping some of the administrative work that gets done, we really have to really think about the fact of how we have evolved. And what I've seen is the conversation is no longer just about policy, it's about implementation, right? One of the biggest lessons that I think we learned from unwinding was really about that administrative capacity matters, right? So we saw that states who had maybe stronger operational processes, who may have already modernized eligibility systems to some extent, information, or they had some trusted data sources, or even some effective automation even back then, they were really better positioned, I think, overall. So I think that as we look ahead to this Medicaid program and we think about all the other changes that are coming, that success is really going to be dependent on something that I think, you and I have believed in for years, and that's good policy really deserves good implementation. Because, if we don't really take the right steps to make sure we're implementing it the right way, then it doesn't matter what the policy is, it's not going to be successful.
Yeah. So let's talk about where we are right now with Medicaid. Some unwinding has already begun.
Yeah.
Certainly, there's some things that were sort of a long tail over the last couple of years from the COVID pandemic. But then, really, there were pauses on unenrolling people for a period of time, and a lot of that initial unwinding has happened. I think at least something like 25 million or more were disenrolled, and more of that's ramping up. What can you say about what you're seeing across the states around the sort of unwinding and the disenrollment process?
Yeah, states have definitely been trying their best, right? They've been really engaging their technology partners, their community partners, to really make sure that they're not that people are being safe, right? That they're able to actually stay on the program and/or find other means, right, for it. But I think, though, that again, one of the things that I think that they're really trying to think about is that, around the whole lines about technology modernization, I think is really important. So, they're really thinking about how can we better connect data, right? So, interoperability, which is so important, right? Is one of the key things. I think they're also thinking about, how do we maybe even automate the routine work that's there, because that's going to get at that administrative capacity. You're talking about thousands and thousands of people. So how do we make sure that we're able to put things in place to really figure those things out and to get that data in a meaningful way, right? And then also the key to communication too. I've seen a lot of states do this with unwinding, but even as we talk about things like the rural health transformation, I have been so impressed with how states have really been getting out there and really meeting with people where they are, whether it's in, in this city or that state or wherever the case may be, to really get at like what are the key issues that are out there and how they can help address it. And I think those are one of the things they learned from the unwinding period in COVID was we really have to understand the needs of these beneficiaries. We have to really talk to the providers. We have to get them involved from the beginning so we can make sure that we're doing things that really make sense for them. So I think that there were a lot of lessons learned through that. And I think that's really been helpful as we think about some of the other things that's going to be coming their way and how they can actually help move those things a little bit faster and a little bit easier too as well.
Yeah, well, you point at something that's really important. Some people who are being unenrolled or disenrolled are being disenrolled because of like paperwork issues versus actual eligibility. And so I think you were just kind of saying that states have learned from many of those paperwork eligibility issues, but those are still barriers. Can you talk about the kind of paperwork or like eligibility things that might just kind of slip through the cracks, right? People just don't have the right documentation, or they're not following up often enough, or what's happening here on the admin burden side?
All of that for sure. So one of the things that I think as we think about how to resolve some of those challenges too, is we really got to think about how technology really should reduce more of the administrative burden and not really create it. So if a beneficiary needs to, have certain paperwork, like how can we make sure that there's technology? So when we think about interoperability, having, ex parte, how do we make sure that that's going to benefit the beneficiary to make it easier for them to get there, right? At the same time, we've got to think about what's going to benefit the eligibility workers too as well. How can they make sure they can tap in that system? How can they make sure that they have quick access to benefits for information? So those things like that. And of course, it's going to benefit the states overall. So, again, lots of lessons learned, I think, as we've thought through this process, as we've, seen states try to overcome some of those burdens. And I think, we'll probably get into some of the new things like work requirements and all of that. So how do we make sure that what we've learned there can really help make this more successful, right? Because, every policy change is really going to be, three things that we've got to think about. One is around, can states operationalize it and how can they do it in a meaningful way? How do they make sure they have the right tools and the technology to make it happen? And then how can they really implement it more consistently and fairly? Again, what's going to be impact for the beneficiary? Because you know what, some things here, if you think about things like some of the things that people would have to do, it's not going to be good for their health, right? And so how do we make sure that we're mitigating some of those issues so we can have better outcomes? Because that's the ultimate goal here, right? Is to really make sure that people are able to have better health outcomes overall.
Yeah, I mean, it's got to be dealing with paperwork to get coverage.
Yeah.
Is certainly not good for your health, especially if you're losing coverage for a period of time.
Right.
When you were actually eligible, right? Like I
Yeah.
understand, right? We want to make sure that only the people are covered are actually
Yeah.
eligible. But the reality is, like, if someone was eligible and they lose coverage due to a paperwork thing, that isn't like a system
Yeah.
failure that is not going to result in a positive outcome at all. It's just
Exactly.
not.
Exactly. And, now, one of the things we've seen is more the 6-month renewals too, right? And so,
Right.
as we're thinking through that, we've really got to, again, think about what we've learned, right? And if government, have the trusted information already, let's use it. Right?
This is like the IR. This
I
is like the
mean,
IR. This is like the IRS thing. You're like, you know how much money I made. Like,
you
why?
know it.
You tell me. Why am I telling
Education
you?
system, if I'm enrolled in that program, right?
That's
This
right.
information,
That's
right?
right.
So that's
That's
where
right.
that automation, that ex parte renewals can really be really important. It's making sure that, where we have the data sources there, let's tap into that. Let's ease that the challenges that beneficiaries will experience, eligibility workers will experience, and even more so what the states are going to experience for sure. So yeah,
Yeah. Yeah.
we're preaching to the choir, right?
Totally, totally. So let's talk about the HR1 OBBA and
Yeah.
the implementation that's happened so far. The headline was almost $1 trillion in federal cuts over 10 years, and where does that money actually come out? I mean, I think a lot of it is tightening up various programs and making
Mhm.
them less generous, if you will, to states and to their residents and to citizens who are eligible for, and other people who are eligible for coverage. But, part of it, some of these things are theoretical, right? They're covered. They're assuming that work requirements will reduce enrollment, reduce
Okay.
eligible enrollees, right? They are assuming that more frequent eligibility checks will reduce the number of like months that somebody is covered. That's my sense of it.
Mm.
Anything else you can say about where these cuts are actually coming from?
I mean, I think, when I think, traditionally, I think what people are really trying to do is really figure out how to make sure you streamline the program. How do you make sure, that people who are able to tap into the program are able to do that? And, whether or not, there's definitely an argument against, about whether you're for work requirements or not. But I think what's really more important to me is, again, really thinking about, uh, you know, how do we make sure that there are more frequent eligibility renewals? How do we make sure that that's easier for people to do? If there are financing changes, make sure, that people are able to handle that. If states are requiring, certain other things that are happening, let's make sure that they're able to communicate that. And so really kind of helping states and the feds to really think through the business requirements for all those different things. So with eligibility systems, with communications, training, appeals, data technology, I think there are different ways that we can look at this, and we ask those kind of questions that we can make sure that the program is supposed to be operating the way it's supposed to be operating. So I try not to get into the philosophy behind these things because I think it
Sure,
depends on who you're
sure,
talking
sure.
to. But one thing we have to realize is policy is written in legislation. Like that's what it is. I was at
You
I
got
was
to
a fed.
implement the law. The
I was
law
yeah.
is written. Yeah.
Yeah, I was fed for over 20 years, right? So I totally get that, and that's what you do. But success is going to really depend on the implementation. And so let's ask those smart questions. And now let's make sure that yeah, you've seen one Medicaid program and you've seen one Medicaid program, sure, but we can still learn from each
Right.
other, right?
Right. Right.
In that. And so let's make sure that we're able to be as successful as possible. And then we're monitoring, right? And we're pivoting, right? The key, I think one of the key questions that people have is about medical frailty. I think that was a
Hmm.
surprise in terms of how, how
There's
issues
basically
are a
a
little more
narrow definition that was
yeah,
created for
yeah,
what is medical frailty. Continue.
exactly,
Yeah.
exactly. And so the burden, of course, on the beneficiary and providers to make sure that they have the right documentation. And so if those are the questions people are asking and concerned about, let's kind of think through how do we make sure that we're being that is able to be operationalized or implemented in a way that really helps keep the right people in the program and all of those things. I think is important. So.
Yeah. So on work requirements, what actually has to be done by a state to implement this? Again, we're moving on from,
Yeah.
there's not a question here. It's in the law. It's got to be implemented. That's
Yeah.
what
Yeah.
it is. So given that, there's been
Yeah.
some limited experience with implement. And by the way, work requirements are technically community engagement requirements. You're
Yeah.
working for a certain number of hours, or you're in school that is, registered,
Right.
or you are doing some kind of community service that's registered in a particular way. So there's a number of options to meet this. So just a little bit of note on implementation. But what do states actually have to do to make this work?
Yeah, so they've got to really redefine their business rules overall, right? And I think I mentioned that a little bit earlier, but so with their eligibility systems, how do they need to work with their vendor partners on that to make sure that any new changes are taken care of? And I've got to say, CMS has done a really good job of not only educating the states on these changes, but also bringing in that vendor community to make sure that they're walking them through the changes so that as they're meeting with their states, they're able to really be more thoughtful about how they can really help and be those true partners. So that's a key piece of it. The communications piece is very, very, very important too. Again, I have got to just think about how great the states have been in terms of really going out throughout their states to really talk about these changes to the beneficiaries, to the providers, to make sure that they understand what the changes are, and to also making sure they're having forums where they're talking with their other community partners and their vendors alike. Another key piece of that is they've got to think about training, right? Those eligibility workers, right, that we talked about earlier, and making sure we're easing those burdens. How are they going to make sure that they have the right information, they have the timely training to do that? And then the thing that I think we don't think about until maybe it's a little bit too late, but I know the states are thinking about this now because I've heard them, is around the appeals process, right? So, again, I'm a beneficiary. It looks like I don't qualify anymore, but I know that I've been in school, but I don't have the right documentation. How does that process work and how timely will it be, right? Because you don't want it to take 6 months for a decision, right? So making sure that you have those right things in there. And then again, really thinking through the data that they do have. Again, if you have it in place, how can we make sure we're easing the burden for everybody involved? And this is really going to be important how states are thinking about this. And then from a technology perspective, again, too, you and I both love our technology companies, right? And that's really important. But we also want to make sure that it's not about the shiny new objects, right? It's about things that are really going to be meaningful and really helpful as people as people go through these changes for sure. So, we've got to just remember that every policy decision really has an operational consequence, and we want to make sure those consequences are really good ones and not bad ones. So to really be helpful through and think through that for sure.
Yeah, definitely. One of the things that states, so just obviously, I'm assuming everyone listening to this, because if you're interested in this topic, you probably know a bit about it, right? That Medicaid is a federal state program, and it's partially funded by the federal government and partially funded to a smaller extent by the states. And it's all usually a huge part of state budgets, right? When you look at what is the state budget, the healthcare component around Medicaid is a big part of it. There's a number of really wonky, weedy things that were included in this reconciliation bill in HR 1 that have, raised some flags for states who are always dealing with, balancing the budget, trying to figure out how to pay for things, trying to figure out how to meet sort of essential services. And there are a number of things that came up, including this thing called provider taxes, which, if, depending on who you listen to, was sort of a circular financing mechanism for filling some of these gaps in Medicaid and other state health funding. So that was one thing, really putting a lid on provider taxes. There were also something around the match for Medicaid expansion to different populations. So on those two kind of weedy topics, anything to say about what you're hearing from states about those things? I mean, they're just putting budget pressure on, I think.
Yeah, that's the thing, because we got to remember that, when these changes are here, but states still have budget constraints, right? They still
Yes.
have resource constraints on our workforce for sure. And again, these are new rules that they've got to grapple with, right? And so, I think everyone's just trying to think through these strategically. I know that in many states, they're really meeting with their provider groups. They've got the hospital groups. You'll see a number of different hospital associations that are really thinking through and either pushing back or asking the right questions to kind of figure out how they can do these things for sure. And so yeah, again, there are a lot of things in there, Lisa, and I will say I am not the expert on provider taxes. There are lots of other people who are.
Neither am I. It's a
But
very complex topic, very complex. But it was filling the gap for a lot of these states,
yeah.
which is like, okay, so now what do you do?
Yeah, exactly, exactly. And it was, let's just be clear, it's a mechanism that was allowable, right?
Right.
And so, it's no, the people weren't doing anything wrong, that they were literally allowable. And so, again, like how can they either, find other ways, to continue to support those populations through this funding, I think is one of the questions they're thinking about.
Right.
So I think time will tell, right? But, there are some studies about that in MACPAC. I will just say I'm not one of the commissioners that it's really
That works on the provider tax topic.
that knows it, but we have some great ones out there that I'm happy to point you guys to if you need to, can really talk more about that.
Absolutely. And then in terms of this concept of, Medicaid expansion, which is something that came out of the Affordable Care Act back in the
Yeah,
day now, I think if I look at the landscape of like which states have expanded Medicaid, I think that door is closed in terms of what happened in HR1 and then where those states are, what they're actually looking to do.
yeah.
Do you have any thoughts on the future of Medicaid in terms of expansion? Probably less expansion, probably moving back to more core populations would be my take.
Yeah, that would be it. And so what I would say then is that, if that's going to be the case, we really have to think about as a nation, what does that mean, right? How do we make sure that those folks are being covered in some other way, right? If they're not eligible for Medicaid for those reasons, because that's not the expanded population, they're not an expanded population, or there is an expanded population, then what does that mean for them, right? How will the exchanges be able to potentially help them? How will employers be able to do more? So I think that really becomes a conversation at that point, right? It's like, if Medicaid is necessarily the answer for those folks, help us figure out what is
What's
the
the
answer for them.
answer? What's the
Because
answer?
yeah,
Yeah.
because let's remember that as people go to emergency rooms and don't have insurance, like what does that mean for the larger population, right? In terms of some of the financial pressure. So I think that's a question that we just need to think about as a country, and really help
Yeah.
them figure it out.
100%. And it's coming up,
Yeah,
it's bumping up against this overall unaffordability on the insurance side.
yeah,
People with employer sponsored insurance are struggling to pay for care because they're not receiving, the same level of coverage they may have received before. And so, just these things are bumping up against each other, and the
yeah,
reality of the cost issues in our market, if you can call it that. So it'll be very interesting to see. We have to
yeah.
have an answer. The answer isn't no coverage. So what is the answer? It's a great
Exactly,
question.
exactly. That's the
Yeah,
question we've got to answer for sure.
definitely. And then in terms of like, from your perspective, looking at what MacPac is doing, what are things is MacPac like that you have seen as MacPac looking at in those spaces around big chunks of Medicaid
Yeah.
policy coverage?
Yeah, so I mean, so I obviously I love MacPac, and again, I will state that I'm speaking on behalf of Verlon Johnson and not
That's right.
MacPac. Okay, so we just
That's
want
right.
to keep that in there, right? But I
Yes.
say one of the things I really appreciate about the commission is that we're always looking around the corner, so not just in front of us, but like what's coming, right? And so MacPac is always trying to help Congress really think about what's next for Medicaid. So that includes things like maybe working even more so on behavioral health. We're thinking about provider enrollment. We think that's a key thing. obviously program integrity is a conversation, I think, in every forum that we're in, right?
Right now,
And
for
so
sure.
as we think about that and we think about the federal role in program integrity, we think about what the states are doing. I think we think about, again, more that provider enrollment. That's where we get into more of the program integrity that I think MACPAC is going to be focusing on. We've done a lot of work already around the HCBS workforce, had some great recommendations in our March report around that. And so we want to continue that dialogue too as we go. And then prior authorization was a
Yes.
huge one that we had for sure as well. And actually in our June report, we really talked about what that looked like around automation, right? And really from that one, we really looked at the fact that it really did and reinforced automation has tremendous potential for sure. And we got to think about that, but we've got to also think about, make sure it's really helping to reduce the administrative burden. It's improving more of the timeliness, right, for sure. And we're supporting those providers, but we also called out that transparency and human oversight still remain essential, right? And so we had some recommendations around that one. And then justice involved youth. That's one of my passion areas for sure. Really thinking about that population and how we can make sure that their transition of care is really meaningful and produces better outcomes for that population. And then also around children in foster care. But I will say that one thing when you think about all the things I mentioned kind of runs through that. And for us, it really is about, again, better policy starts with better information, which leads to better implementation for sure. And so, for example, I mentioned in our March report, we talked about HCBS workforce. We include a recommendation in there to improve HCBS workforce wage reporting because we realize that better data leads to better payment decisions. And so really want to make sure there's a way for us, for the states to really gather the information more. So, lots of exciting things there. And just because I can, I'm going to put in a plug for folks to go to macpac.gov. We have a lot of different resources there, briefs. You can also register for our public meetings there as well. So I encourage people to engage as much as possible and to really help the commission and others to really make this program even better because it is important.
Yeah, absolutely. Well, you're pointing to an area that you and I are both really interested in, which is the data and the technology and the modernization.
Yeah.
So, of course, because we have more than 50, I always get it wrong. What is it, 64, 67,
Yeah.
something like some number of Medicaid programs. I never in my entire life been able to remember the exact number when I'm asked to. More than 50, that's for sure. Medicaid programs, when you talk about the states
That's
and the
right. That's
territories
right.
and things like that. And
Right.
so we have a bunch of Medicaid programs, and a lot of them are working in silos because they have to procure, technology
Yeah.
individually in many cases. And that's a huge barrier, especially when we talk about some of our smaller states and territories and jurisdictions, right? And so, I think this area, again, you and I are both really passionate about and work on. And so, what kind of things, what's missing for states and state systems here to do this critical implementation work for all these policy changes?
Yeah, I mean, I think we talk about data probably more than we talk about, everything else in our life for sure. But I think that we have to because I really think healthcare, already, like I said earlier, we have plenty of data, right? So the challenge is really more around using it effectively for sure. So data doesn't improve health, right? It doesn't, right? But better decisions improve health. And so we need to really thinking about when we have that data, can it help us determine who's going to be at risk? Where are the disparities? It can help us with that information. Can it share with us what's working? Absolutely, right? Can it share with us where there's more burden and administrative or otherwise? And it can also maybe tell us where some resources to go. So that's where I think the value really is when it comes to data. So the value isn't in collecting it because I think we're getting pretty good at that, right? I think we got that. It's really helping other states, feds, and individuals, right, to make better decisions about their care. So I think that's really important as we think about data. It's not just how do we collect it and do we have a cool way to obtain it, but what can it do? And so as we talked about as we're thinking about eligibility determinations, right? Hey, we've got the data. Let's use that data to make these informed choices, not just to have that data in all these great agencies. Let's use it. Let's put it together. Let's put it together so we can figure these things out for sure, which I think we've been doing a really good job with our ex parte and other things like that for sure.
Yeah, I mean, I think we definitely agree that there is, if there's promise of like AI and automation anywhere, it's
Yeah,
probably surfacing the right information to make decisions because you have, like as you
yeah,
noted, huge amounts of data now in different places,
yeah,
maybe siloed in different places, but also just you know, like getting that right signal out of a bunch of noise
yeah,
is probably one of the things that we can do better with AI and automation. You also
yeah,
mentioned, of course, earlier a little bit on the work MacPac work on prior
hmm,
auth and Medicaid. I mean, prior auth in general is just so rife for automation, right? Because
yeah,
what you're looking for is you're looking to make sure that a particular service, a particular claim matches the coverage rules. That is something that
exactly.
you should be able to do with technology and automation without having it take a lot of time, require a lot of manual effort. That's a thing that can absolutely make people's lives better. As if you should be covered, that should happen nearly automatically.
Yeah,
And
that's it.
so, super important.
Yeah, and so you're covered, great, right? If you're not covered, then let's talk about bringing in the maybe we have human loop. Let's make sure we have parameters around that to make sure the right decision was made. But I agree with you. If it's a slam dunk, let's just count it a point and move on, right? So that those folks can get to the coverage that they need, and we don't have to worry about more of the administrative burdens on eligibility workers and others to continue down that path when it's obvious for sure. Yeah,
Yeah, I think in practice, what we see, of course, is that doctors, in particular those in lower resource settings or those in safety net
yeah,
settings who might be serving patients with Medicaid, may not have the most updated health IT systems. They may not have the ability to document in the exact way that, like, let's say the Medicaid program wants to see. Those are
yeah.
investments that should be made, right? To make sure that we can share those information. And if you look at just the basic like laws and regulations, they're actually already in place. Those things are already required, but they're not actually fully implemented. It's very interesting.
Yeah, I agree with you on that one. And so like how do we make sure that more people are familiar, that they're able to tap into those resources? And as we think about budgets and things like that, like how can we make sure that there's allocations to support those smaller providers so that it is across the board? I agree. There's lots of different things we can think about around that for sure.
Yeah. Anything you want to share about what Acentra is doing around modernization with technology and data modernization with the states right now in preparation for this and in service of this work?
Yeah, so while we're not an eligibility provider, we do try to make sure that we're supporting our states in every little aspect that they have, for sure. We do core claims, we do provider enrollment, and so as we think about things like provider enrollment and some of the conversations around that, how do we make sure that we are, really supporting our states in a very meaningful way. We are also do a lot around assessments, and so as we think about things like medical frailty, right? Like how can we make sure we're leaning in that area to really help ease the burden from our state partners. So we're having those kind of conversations for sure. And then, as you know, we're one of the founding companies that started that Safe AI in Medicaid Alliance, or SAMA, right?
Yes.
And so I am proud to say that I think we have about 40 states now and over 100 companies for sure. But for those who aren't aware, SAMA really brings together, states, policy leaders, technology experts, and industry partners around one central idea, and that is how do we implement AI responsibly in Medicaid. There are some states that are further along in the path on how they're thinking about it. Other states are like, nope, not in my state, right? And so how do we bring together each other, really think about, the fact that, yeah, AI isn't the goal, but responsible AI really should be and is the goal. And so what I really have appreciated about SAMA is that it's very practical. We're not talking about AI in abstract. We're really talking about real Medicaid use cases for sure. We've got a number of different groups that we have focused on specific issues, but really trying to really figure out, what does responsible AI look like, and making sure that we have those principles in place to really help states and others to really think more meaningful about it and make sure it's used in the right way. So
Yeah.
lots of good action there for sure.
Absolutely. So if you were sort of advising a state Medicaid director, what is the first thing you would tell them to prioritize on their probably unending modernization journey?
Oh my gosh. That's that's a good
What do they
question.
do with their
Uh,
next dollar?
with their next dollar. Gosh, I don't know if I want that kind of responsibility, but I think it's really about making sure, okay, data, because we talk about data, right? Making sure that we're thinking about how do we connect the data, right? I think that's really important. I think probably, as we've talked about, making sure that as we think about some administrative burden, how are you able to automate some of that work for sure? The communication piece, I think, is really important for sure. And then just because we live in these United States, let's make sure we're able to adapt and pivot. As quickly as we can. But I think as I think about just like what's happening around Medicaid, I think we have an opportunity here to really make Medicaid simpler, to be more responsive, to be less burdensome, and also be more effective. And so whatever that takes, whatever those investments are to do that, I think that's exciting. And I think that's something that I would say is think through those things, right? To make sure that your program is really helping the people that you really feel should be helped and should be helped, right? Because, overall, we want healthy Americans for sure, right? And isn't that what we've heard over and over again, is how do we make sure that we have a better, healthier America for sure?
Yeah, absolutely. So part of this podcast is that the conceit of the podcast is we talk about the policy stack. And so Medicaid is a complex program that has been developed over many years, since the 60s, when Medicaid and Medicare were created, Social Security Act. So that's really where that's the founding, right? The statute is the Social Security Act, Medicaid, CHIP, the Children's Health Insurance Program. The HR1 as well, which was recently signed last year.
Right.
A lot of the things we didn't touch on today are the Section 1115 waiver authority, which we've talked about in the podcast in the past with CMMI, the Centers for Medicare and Medicaid Innovation. The financing, which we touched on very briefly, but there's the federal state match FMAP, which is anyone who's a Medicaid director or working in Medicaid financing is living and breathing that and understanding which portion the federal government will pay, which portion they have to come up with. There's just tons of regulation and guidance coming down from CMS about Medicaid at all times. Yeah. There's those state Medicaid director letters, which give a lot of guidance. Those are always really fun for any Medicaid director and folks working in the states.
And if you have to write it, as someone who's had to write them, help write them. Yes,
they're so complex that's like. In particular, those SMD letters are just they're a perfect example of the volume and depth of sub-regulatory guidance that is like every day for folks working in Medicaid. It's not just a law. It's not just a regulation. It is also endless program requirements and like guidance as well. So that one falls into the policy stack. And then the eligibility and enrollment operations, there's tons of those things. Now adding the medical frailty, the 6 months redeterminations, 80-hour work community engagement verification, ex parte renewals, all those things that we talked about. That's also like guidance that makes up those are policies. They're de facto policies, or they are policies that have to be implemented. The coverage and the delivery. You talked about HCBS and waivers. Expansion groups, managed care we didn't even touch on, which is obviously a huge amount of delivery of, there's so much here.
Yes.
Then there's the state.
I think what is it, like almost 80% of the population? Yeah, that's on managed care. Yeah,
covered on managed care. Yep, managed care. Then there's also the place that I lived a lot in, which you probably are very familiar with too, is all those state systems and technology rules, right? The Medicaid enterprise systems, the modular certification, E&E eligibility enrollment systems, MMIS, automation, AI, interoperability. There's a ton of stuff there that states are dealing with. There's the oversight. You obviously mentioned MACPAC. Yeah. There's MACPAC giving guidance to Congress about Medicaid. There's CMS oversight. There's, all of those things. And then there's the workforce stuff as well. So those are some things, anything you can think we missed of like what makes up the whole policy stack for this world.
Oh my gosh. So you covered it with the technology, the data, the analytics, the AI stuff for sure. I mean, and then, the providers, I mean, it's all of that, right? All of that. It's a lot.
All that
No
stuff.
one ever said that Medicaid wasn't complex, right?
It's super complex.
It's super complex, but it's also super important. And so the more that we can understand all those different intersections and all the key pieces of it, then I think we can make sure it's a very strong program for the people who need it the most, for sure.
Amazing. Well, that's our time today. Obviously, please reach out to Verlon Johnson and the Acentra Health team for just all of this expertise. Thank you so much for spending your time with us and sharing some of your immense knowledge about the Medicaid program, and really appreciate it. Thank you so much.
Thank you. Take care.